Hello, my name is Dr. Taya Orosano, and I will be talking about behavior management in pediatric dentistry, non-pharmacologic considerations. So I'm going to have you review the goals. So we want to review the effective communication between dentist and patient, review ways to decrease fear and anxiety, review ways to extinguish inappropriate behavior, and understand how to deliver quality dental care safely, and to review the relationship between the child and the dentist. How would we achieve all those goals? We want to understand childhood characteristics and milestones based on age. We want to know child-appropriate dental terminology. We want to better understand IQ and its dental implications. We want to understand behavior classifications, understand the different non-pharmacologic behavior management techniques and when best to use them. And we want to recognize effective dental strategies. The treatment triangle is the relationship between the dentist, the pediatric patient, and the parents or guardians. It is a 1-to-2 relationship versus in adult dentistry, where it is you, the dentist, and your patient. In pediatric dentistry, it's you, the parent, and the child. The child always comes with a parent or a caregiver or a guardian, grandparent. And at the bottom of the bottom right of the screen is the treatment triangle, and at the apex is the child patient, and at the bottom, the base, left and right is the family and the dentist. The society is in the center, and these arrows, if you look at them, are kind of like going back and forth between the parent and the child, between the dentist and the child, and then a communication between the dentist and the parent. So the child is at the apex that we talked about and is the focus of attention of the family and the dental team. Human development is not unitary. There are several important aspects of child development, and no single aspect of child development can be used to assess development. It's important to know the personality characteristics of different ages and their relevance to dentistry. Age 2 years old, the child is geared to gross motor skills, running, jumping. They're the ones that are going to climb the chair. They're going to be all over the place, touching, grabbing everything. They like to see, they like to touch. They're very attached to their parent, and they usually play alone, rarely sharing, has limited vocabulary, and will show some early sentence formation, and is becoming interested in self-help skills. They're the ones that they want to start brushing by themselves. So the parent may tell you that, oh, they're starting to brush by themselves, and you let them know a 2-year-old is not able to do a good job with the brushing, but it's good to encourage them because that's how they develop those self-help skills. At about age 3 years old, they are less egocentric. They're very eager to please and they have a very active imagination. They like stories and they still are closely attached to their parent. In my practice, for children that are 2 years old, I generally do just a little bit of verbal communication with them. Most of the time I sing to them. And about 3 years old, that's when I start to talk to them about things like unicorns or a cartoon character, because at this age they like for you to tell them stories and they have a very active imagination. At this age you can bring things to life, so you can give life to inanimate objects. They really love that and respond very well to that. At about age 4 years old, they're starting to try to impose their powers. So this is the age when you want to start to bring in, oh, these are my rules. We can or cannot do certain things when you're at the dentist. At this age, they also participate in small social groups. They're reaching out as their expansive period. They show many self-help skills, and at this age, they know thank you and please. At about age 5 years old, all of the information they have gathered, all the skill that they have learned, they start to consolidate them. They're more deliberate in the way that they act and interact with people. They take pride in their possessions, relinquish comfort objects such as a blanket or a thumb, and they're starting to play cooperatively with their peers. And if you remember, we talked about 2 years old. They don't share. They're playing by themselves. By the time they get to age 5 years old, they're more involved in their society, pretty much. This table is just the exact same thing that we talked about, the psychosocial traits of 2, 3, 4, and 5-year-olds. Here are developmental milestones, and these are physical developmental milestones. I will have you just kind of take a look at them and just kind of like learn them, go back and learn them. The most important, the takeaway from this table is, as a child gets older, they're able to do more sophisticated physical developmental characteristics. So at age 2 weeks, they're focusing on light. By age 3 weeks, they're lying on their stomachs. They're lifting their chin. At age 7 months, they're starting to roll from back to stomach, all the way until when they're standing at age 14 months, and up until when they're about 12 years old, they're starting their menarche, which is the first menstrual period. And the most important thing in this table is to note that there is an average age where you expect to see certain milestones in children, but there is no hard and fast rule. Every child responds to, it develops these traits at different ages. So there is a range. What you're looking out for is to see if a child is way out of their range. Are they doing things too early where they're precocious, or are they real behind their peers? That's when you start to be concerned. So on the far right, that column just gives you a range where you expect the developmental tasks to be accomplished. Physical development is a child's total physical growth and efficiency from the moment of conception until they reach adulthood. Relating physical changes to specific chronologic ages led to the establishment of the developmental milestones that we talked about in the slide prior, and this is a means of assessing individual children. Age-specific skills have been derived for social development, and these take into account both interpersonal relationships and independent functioning skill. It's important to note that the younger a child is, the less reliable the test score. Another score that we use to assess a child is the intelligence quotient, and this assesses quantified mental abilities in relation to the chronologic age, and the formula is the mental age over the chronological age times 100. This table kind of gives us the severity of intellectual disability. The term mental retardation is no longer in use, is no longer seen as appropriate. So just where it says mental retardation, please just kind of switch it out with intellectual disability. Variables influencing children's dental behavior. So there are certain things that will influence the way a child will behave in your chair. Anxiety or fearfulness are usually a personality trait. So when a child comes to your office, the first thing you want to do is just kind of like talk with them. When you're talking to them, you're trying to like evaluate what their personality trait is. Some kids are shy, some kids are outgoing, and some kids are slow to warm up, meaning you just have to get into talking with them, communicating with them a little more, and then they open up and they're super bubbly. And this personality traits affects a child's behavior to a large extent and will determine the success of your dental appointment. Another thing that influences a child's behavior is maternal anxiety. If the parent is super anxious, the child's probably anxious as well. Medical history is also a factor that may influence their behavior. In children that view medical experiences as positive are more likely to be cooperative, and the emotional quality of past visits, rather than the number of visits, is significant in determining how a child will behave. So a child that has had one traumatic experience will probably be less cooperative than a child that has had multiple good experiences. Surgical experiences adversely influence behavior at the first dental visit, but usually afterwards it's not, just because they expect to come to the dentist and to feel pain. So if they come to your office, I try to make sure my first dental visit is super chill and super easy, such that it's just, maybe like a cleaning appointment or a consultation, just to make it kind of like ease the patient into the dental treatment. Awareness of the dental problem, a child that knows that there's something wrong is probably going to be a little bit more anxious than a child that just feels like, oh, everything's fine and dandy. How do we classify children's cooperative behavior? One way is the Wright's clinical classification, and it places kids in 3 categories: cooperative, lacking in cooperative ability, and potentially cooperative. A cooperative child is relaxed, minimal apprehension, enthusiastic, and you just have to shape their behavior, establish guidelines. They do great. Lacking in cooperative ability is children that are very young, about 3 and under. You cannot establish communication and you don't really expect them to comprehend. Or children that are that have certain debilitating or disabling conditions, like children that maybe on the severe autism, or Down syndrome, or children with like intellectual disability that you cannot expect them to cooperate. And these kids are also known as pre-cooperative. Potentially cooperative as are children that do have a behavioral problem. They can cooperate, however, they're not cooperating. So you got to use your clinical judgment to kind of like try to figure out, why is this kid not behaving as like I want them to? How can I modify their behavior so that they are cooperative? These children are maybe timid, tense, cooperative, whiny, or defiant, uncontrolled, just all over the place. Another behavior rating scale is the Frankel, and that goes from rating 1 to 4, where 1 is definitely negative, and 4 is definitely positive. And in my practice, generally, I tend to use the non-pharmacologic behavior management techniques for children in the rating scale 3 and 4. And sometimes I can get a child with a rating 2 to be able to accept treatment with non-pharmacologic behavior management techniques. But sometimes, you just have to maybe use nitrous to help them get the work done. Usually children that are rating 1, definitely negative, almost always have to get the pharmacologic behavioral management technique. Maybe may not even be able to get the work done with nitrous. You may have to sedate these kids or completely put them to sleep with like general anesthesia. So information gathering, super important. You want to learn about the patient, you want to learn about the parent, what are their concerns, and at that time you're trying to like figure out what's going on with this kid. You at the same time paying attention to the child to see, do you think this child will be able to cooperate? Their nonverbal communication? Are they hiding behind the parent? Are they crying, whining? Are they just scared and won't let you come close to them? Will they not get in the chair? Will they not make eye contact? Are they not smiling at you? So at that point, you just kind of like try to figure out. Your mind is kind of is thinking, how am I going to manage this kid's behavior? Um, at the same time, you're learning about the reason why the patient or the parent came to your practice. It is important to know that parents of pediatric patients are the ones that really teach the kids what they're supposed to do and what behavior is forbidden. And the socioeconomic status of parents has some bearing on their acceptance of your management methods, whether it's your restorative treatment plan, whether it's your behavior treatment plan, the social construct of this patient's family. It's super important. Societal changes have created dynamics that indirectly affect the behavior of children in the dental offices. Changes like blended families, same-sex families, single-parent families, and maternal age. Maternal age could either be older moms having kids now, or with the increase in teenage pregnancy, really young moms. You just have to be able to like figure out what's going on in this patient's social background and try to modify your treatment plan to fit. So, still talking about information gathering, generalizations usually have been made that a future-oriented, conscientious middle-class parent will tend to seek dental care readily and cooperatively, and that they accept brushing and dental checkups as a matter of course. Not always true, but it's something to consider, especially if you're working in a low socioeconomic environment. You need to take into consideration that the parents may have a lot of things going on with them. They may have um, multiple jobs, so they may not be able to bring the patient to the appointment. They may need like grandma to bring the patient, or they may miss appointments, or they may have issues with like getting to the appointment. They may have transportation problems. So it's important to take that into consideration when treatment planning for every child that you're seeing. So there was a study where they divided um, behavioral management techniques into two. There was tell, show, do, positive reinforcement, voice control, and the use of a mouth prop in one. And then there was restraint methods, sedation, and general anesthesia. And they had three groups of parents and just showed them videotapes. The first two groups did not find the restraint methods, sedation, and general anesthesia acceptable. However, they did something different with the third family. They gave a verbal explanation to the parents and then showed them the videotapes. And they found that the third group of families accepted the restraint methods, the sedation, and general anesthesia more readily. And this just lets us know that all they did was just kind of like give a little spiel, explain to the parents the two different groups of techniques, and we found that the parents that got a little verbal explanation were more accepting of the more adverse behavior management techniques. So this just points out the importance of communicating with parents. Communication is key. It's critical to develop a rapport with with the parents. Several methods of coping with parents and children's behaviors have been suggested. However, the most important thing is to try to improve the way you communicate with the parent. And if you're able to get your message across to the parents, you'll have them on your side, they're on your team, and they're working with you. So what are the strategies? How do we achieve non-pharmacologic behavior management techniques? A primary objective is to lead the children step by step so that they develop a positive attitude towards dentistry. And every step fits on the next step. Each step needs to be a positive experience so that you're able to lead them to the next step until you get to a point where you're completing the procedure. We can use things like pre-appointment behavior modification. These are things that are said or done to positively influence the child's behavior before the child enters the dental operatory. It prepares the patient and it eases their introduction into dentistry. It could be things like films, videotapes, or modeling, like using the patient's sibling or other children. So they see this older sibling getting the treatment done. Oh, that's easy, I can do that. They get in the chair, they're able to get it done as well. And the merits of modeling is to stimulate new behaviors, to facilitate behavior in a more appropriate manner, to disinhibit inappropriate behavior due to fear, and to extinguish fears. Fundamentals of behavior management. We want to instill a positive approach. We want to have a positive approach. These are the attitudes and the expectations of the dentist. Everyone's super happy, everyone's super pumped, really engaging, good team attitude. You need to be warm and you need to be interested in the child. You need to be very organized. Delays and indecisiveness can build apprehension in young patients. Truthfulness is important. Don't lie to your patients. Generally, you lose their trust when you lie to them. You can use euphemisms, like instead of saying, oh, I'm going to use this needle to pinch your gum and then put some anesthesia and your tooth is going to go to sleep. You just say, I'm going to spray some medicine drops next to your gums, or you can say, I'm going to spray some medicine drops on your tooth and your tooth is going to go to sleep. You've said the same thing, but in a nicer way. It's a nicer way, easier way for them to understand, and you're not scaring them. A dentist that sees children needs to be tolerant. You should be able to be rational when they're misbehaving. You should be able to maintain your composure when a child is misbehaving. In addition, you need to be super flexible. If one thing's not working, be quick to adapt. So you can change that technique. If this is not working, let's try something else. Communication with children. The first objective in the successful management of the young child is to establish communication. Involving a child in a conversation not only enables the dentist to learn about the patient, but also relaxes the child. So patient comes in, you compliment them. I like your bow. Oh, is pink your favorite color? Or maybe they have like a unicorn headband on. Oh my goodness, do you like unicorns? I love unicorns as well. So verbal communication with younger children is best initiated with complimentary comments, followed by questions that elicit an answer other than yes or no. This just prompts the child to speak and communicates with you, and it really helps to relax this child. It's also good to establish the communicator. So the dental assistant is probably the one that gets the patient from the waiting room and prepares the patient in the chair, is talking to them, getting to know the child. By the time the dentist arrives, the dental assistant usually takes a more passive role. And it's very important that the communication occurs from a single source. If at any point I find my dental assistant talking, I generally just step back, allow her finish, and then I take over again as the communicator. It's important that your message is clear and you use euphemisms to explain your procedures like we talked about. Pre-appointment behavior modification. We already talked about this: letters, mailings, videotapes, patient models. The euphemisms that we talked about, Instead of saying rubber dam, you can see the raincoat. Instead of the water syringe, you can see the water gun. Instead of the high speed, you can see the whistle toothbrush. Instead of the low speed, you can see the motorcycle or the bumpy toothbrush. Another behavior management technique is voice control. These are sudden and firm commands that are used to get the child's attention or to stop the child from whatever negative behavior they're exhibiting. Another method of voice control is monotonous, soothing conversation, which is supposed to function like music set to a mood. It is an attempt to influence behavior directly, not through understanding. And I use this a lot with the 2-year-olds. When we're doing a lap exam or a 2-year-old and under. First time at the dentist, they're not happy, lap exam, and they're crying, fussing. I just keep singing that monotonous, soothing song, and I just keep going. After a while, the child just relaxes. It's very, very helpful and effective. Nonverbal multisensory communication, like body contact, like a hand on the shoulder, and this really helps the child to relax, and it works well in kids 7 to 10 years of age. Eye contact is also important, and any child that avoids eye contact is often not fully prepared to cooperate. Pay attention to your patient's heartbeat. If there's a rapid heartbeat, or you notice that they're sweating, it helps you know that the child's probably nervous. Every effort should be made to not to tower above kids when you're talking to them. I generally just drop to my knees or squat in front of the child, be at their eye level, and this is super friendly and it's less authoritative, and it helps the child really relax. It's also important when you're working to just keep looking at the child, keep looking at their faces, because some children may be like nice and cooperative to begin with, and sometime during the appointment they get tired, so you have to keep communicating with them, you have to keep checking in with them. Some kids are criers, that they're silent criers, where they're crying but you cannot hear a peep. So it's important to just keep checking in with that child to make sure that they're doing well while you're working on the tooth. Tell, show, do. 3 steps: you tell the patient, verbal explanations in age-appropriate phrases according to development level of the child. You show them, you demonstrate visual, auditory, olfactory, and tactile aspects of the procedure in a carefully defined, non-threatening setting, and then you do, meaning you complete the procedure without deviating from the explanation. This helps to teach the patient important aspects of the dental visit, and it shapes the patient's response to procedures. It shapes the patient's response to procedures through desensitization and well-described expectations. Positive reinforcement. This is when you want to reinforce a good behavior in the hopes that this behavior will be repeated. There are 2 types of reinforcers: social reinforcers, which include verbal praise, voice modulation, facial expression, appropriate physical demonstration of affection like a hug, a high five. Hey, Johnny, you did such a good job. I'm really proud of you. Thank you for staying still. Thank you for keeping your mouth open really wide. It helped me, so I was able to fix your tooth really quick. Non-social reinforcers like tokens, stickers, toys, make sure they're age appropriate. Make sure things like balloons, like the kids don't have a latex allergy. Another technique that works really well for me is distraction, especially when I'm trying to do the local anesthetic. I have the patient kind of put their chin up, and I tell them, oh, I'm going to spray some medicine drops next to your tooth. I leave my topical on nice and long enough, and I position myself so that the patient is not seeing what's going on because their chin is way up in the air. And just before I penetrate the soft tissue, I give the cheek a little shake or a wiggle, And usually they don't realize that has happened. When I start to deposit, remember, because of the pH of the local anesthetic, that's when they feel the discomfort. I tell them to wiggle their fingers and wiggle their toes. We try to make it a game where they maybe wiggle your left fingers and your right toes. And while they're paying attention to trying to get that task done, they're not paying attention to the local anesthetic that's going on. Distraction is used to decrease the perception of unpleasantness and to avert negative or avoidance behavior. It is used to increase attention span. An example is like giving a child a hand mirror to hold while the dental procedure is being done. You obviously don't want to do that when you're doing the local anesthetic because they'll see the needle. You may do that when you already numb the kid. They could use the mirror to watch you put the rubber dam on. They could use the mirror to watch you do the procedure. And if at any point you're getting to a point where there's going to be bleeding or something uncomfortable, you can distract them with like stories, have them put the mirror down. Another thing that you could do is maybe have like a TV or an iPad mounted above the patient so they're watching TV shows or cartoons while you're getting the work done. Behavior shaping. This is when you slowly develop behavior by reinforcing successive approximations of the desired behavior until the desired behavior comes to be. For example, I have a patient come in the chair. We need to use nitrous, and they're not going to have the nose on. So I take the nose off of the attachments. I put it on the patient's nose. Usually smells good. We have like different flavors, different scents. I go for the patient, and we count to 10. We take it off, and then we attach the tubing to the nitrous nose. We'll put it on again, count to 10, and take it off. And gradually until we have the air going through the nasal tubing, through the nose. They have the nitrous on, they calm, they relax, we get the work done. Usually it involves tell, show, do, and it requires that the desired behavior is observed before you move to the next step. Example of using a mirror to see what's going on, and it really helps the patient to be not afraid because they're seeing what's going on and they're like, oh, this is not too bad, I can do this. Problem ownership. So there's you messages and I messages. You messages carry the implication that the child is wrong. An alternative is to send the I message, which is often used with the intent to be assertive without putting the listener on the defensive. You're avoiding accusations. You're using this I messages to take ownership for your feelings rather than implying that they're caused by another person. An example is, I'm really unable to help fix your tooth since we can't get you sitting on the chair, rather than, oh, you didn't sit in the chair, now your tooth will not be fixed. So, or you say, I'm really sad that we were not able to have you sit in the chair, versus, you didn't sit in the chair, and now I'm mad at you. Non-pharmacologic methods. We're continuing on active listening. Listening to the spoken words may be more important in dealing with an older child than a younger child, because the older child is probably able to express themselves better. And it's important to know that active listening is the second step in communication. And after listening to this kid, you have to give an appropriate response. And the appropriateness of the response depends primarily on the extent and the nature of the relationship with the child, the age of the child, and the evaluation of the motivation of the child's behavior. Retraining. Children who require retraining approach are kids that display considerable apprehension and negative behavior. So the objective is to build a new series of associations in the child's mind. For example, I use this a lot in kids that maybe have had a bad experience at maybe a general practice, and they're seeing you for the first time. what I do is I'm on my A game, super chatty, super fun and animated. And my goal is to make that appointment easier, much easier and less threatening than the previous appointment. They're the kids that I leave the topical on for a lot longer. They're the kids that I use distraction really well for. I bring out the iPad, I have them pick a show, pretty much get the work done without them realizing that it's been done, and it is a lot of fun for them. And it's important to note that if the original stimulus and the new one is similar, the response will be similar. So if the same experience they had at the previous dentist is what they have at your practice, they're probably still going to be afraid. Nitrous oxide often works when retraining a child because it offers a different experience. Aversive conditioning, hand over mouth exercise. Its purpose is to gain the attention of a highly oppositional child so that communication can be established and cooperation obtained for a safe course of treatment. So it's, for example, the child is screaming, kicking, you put a hand over their mouth and you tell them that I am not going to remove my hand until you stop screaming and kicking. Once they stop and they listen to you, you remove your hand and you proceed with the treatment. Or you start communicating with the patient, trying to understand why they're behaving a certain way. This is no longer in use. It is no longer considered as appropriate, as just in here for historical purposes, so you can be aware of this behavior management technique. Parental presence or absence. This involves using the presence or absence of the parent to gain cooperation for treatment. And there's a wide diversity in practitioner philosophy and parental attitude regarding the parent being in the operatory or not. Some practitioners will not see a patient with the parent in the room no matter what. And some parents will not be outside of the operatory no matter what. So it's just both practitioner and parent need to come to a mutually agreeable situation. So if the parent feels like, oh, I have to be in the room, then that may not be the practice for them. They may need to find another practitioner that is going to be willing to have them in the room. Communication between dentist and child is paramount. We cannot overemphasize communication. It demands focus on the part of both parties, and children's responses to their parents may be beneficial or detrimental. Each dentist needs to determine the communication methods that best optimize the treatment setting. You will not use the same behavior management technique with the 5-year-old that you would use with a 15-year-old. You need to recognize your own skill. For me, I'm a good singer. I love to sing, so it's a skill that I use very often. Use it for the children 2 and under. I use it for the older ones too, like the 3-year-olds, the 4-year-olds, the 5-year-olds. I've even used it for a 10-year-old. There's kind of anxious, apprehensive. I just start singing, and usually it just really relaxes them. Recognize the abilities of the child and the desires of the parent involved. So establishing communication authority, your main goal should be to prevent uncooperative behavior. You need to listen to the child's questions. You need to acknowledge the question and repeat it back. And you also need to establish authority. Effective dentists establish rules for the patients to follow. They teach their patients and they demonstrate kindness. So what are the practical considerations? Scheduling. Morning appointments are suggested for children because children are more alert and the dental team is fresher in the morning. In my practice, I do not see any child that is 7 and younger after 1 p.m. I may see a couple 7, 8-year-olds at about between 1 and 2, but after 2 o'clock, I want to see older kids. Just because, you know, a 3, 4-year-old that is scheduled at your practice at about 3 p.m. for a stainless steel crown, that's not going to work. The child is not going to be alert. Child's probably going to be tired and cranky. And you, as the practitioner, you've already worked hard that day. So that is not the time to be seeing that type of patient, because you're more likely to not be tolerant or calm or patient enough to help this child. Parent-child separation. Excluding the parent from the operating room can contribute towards development of positive behavior on the part of the child. And if you are a practitioner that requires the parent to remain in the reception room, you could justify it by saying the parent often repeats orders, which creates an annoyance for both the dentist and the patient. The parent injects orders, becomes a barrier to development of rapport between the dentist and the child. The dentist is unable to use voice intonation in the presence of the parent because the parent may be offended. The child divides attention between the parent and the dentist divides attention between the parent and the child. Unfortunate but true. And a parent can be a major asset in supporting communicating with a disabled child. So usually if I have a special needs child, I always have the parent in the room. Or if it's a child that's about 4 and under, I almost always have the child in the room, because they're able to provide important information and interpretation for you. Very young children that have not reached the age of understanding full verbal communication, that have a close symbiotic relationship with their parents, usually have their parents in the room. So children 3.5 to 4 years old will benefit from their parents being in the room. Tangible reinforcements like gift given should be used as tokens of affection or a reward, not as a bribe. Another thing to consider is your dental attire. There is really no evidence, but it is a lot of practitioners and their staff opt to wear colorful scrubs in clinic gowns. Just because some kids see the white coat and then they're scared, even before getting the work done, they're already apprehensive because they see you in a white coat. So a lot of practitioners tend to wear different colors these days. We want all of our patients to walk out the dental office smiling. So this big, huge smile on this really cute, adorable young man is what we want our patients, all of them, to look like once they're done getting the treatment done at the dental office. And it just takes a lot of practice, really. Try to develop your style of behavior management techniques. Any questions? If you do have any questions, please feel free to email. My email address will be on the packet that you received, and I hope you enjoyed this. Thank you.